Hello, my name is John Moyer, and I want to welcome you to the NIH Office of Disease Prevention's Methods Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions that have been submitted via the Zoom chat pod at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in a few weeks. Lastly, we would appreciate your feedback about today's webinar. Upon closing, you will be asked to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Dr. Moyer. Today's speaker is Dr. Marta Mulawa. Dr. Mulawa is an assistant professor at the Duke University School of Nursing with a secondary appointment in the Duke Global Health Institute. She's also a scholar at the Duke University Population Research Institute. With over 15 years of experience in NIH-funded social and behavioral intervention research, Dr. Mulawa focuses on addressing health disparities in low-resource settings, particularly related to HIV prevention and treatment. She has extensive experience working on teams conducting community randomized and cluster randomized trials, and is a contributor to the 2024 Prevention Science Supplemental Issue on design and analytic methods to evaluate multi-level interventions to reduce health disparities. Currently, her research focuses on developing and testing a digital health intervention to improve treatment adherence among youth living with HIV in South Africa. It's my pleasure to welcome Dr. Marta Mulawa.
Thank you so much for that introduction, Dr. Murray. It's really exciting to be here to share this presentation today. I'm grateful to you and to the NIH Office of Disease Prevention for the invitation to present this Mind the Gap webinar. And I'd like to start by acknowledging that the work that I'm going to be presenting today, work that was published in Prevention Science in January, was a collaboration with several of my colleagues and co-authors at the Duke University School of Nursing listed here. And I want to particularly acknowledge Doctors Sharon Doherty and Wei Pan for their critical roles in bringing this group together and in helping to conceptualize this work. We were really honored to be selected as one of 12 excellent papers featured in this special issue in Prevention Science on design and analytic methods to evaluate multi-level interventions to reduce health disparities. And we deeply appreciate NIH for issuing this call, which aimed to highlight innovative approaches in this space. And I just want to say that our group was immediately drawn to this call for papers on this topic because the call itself was grounded in an acknowledgement that, reducing health disparities and improving health equity requires addressing structural racism and other structural determinants, and that effectively doing so requires evidence-based multi-level interventions. And many of us here at the Duke University School of Nursing, we're really passionate about this work. We think deeply about how to develop and test interventions in a way that balances, the methodological rigor with practical design, feasibility, acceptability, as well as community input and ethical considerations. And balancing these types of factors was described as a key focus of this special issue. So I point you all to the special issue if you're interested in reading more. I'm going to begin this presentation by discussing systemic racism and mental health in schools. I'll then describe our hypothetical multi-level intervention to ground our discussion. I'll then share a proposed evaluation design, measures, and analytic sample. And then I'll discuss some sample size considerations and end with some conclusions about how to best advance our ability to evaluate synergies within multi-level intervention studies. And the plan, as you've heard, is that we'll have some time for questions and answers at the end of the presentation. So please do put your questions in the chat. Okay, so I'd like to start by sharing how our team conceptualized systemic racism and why we decided to focus our paper on addressing mental health in high schools. So in our work, we draw upon definitions of systemic racism as being inclusive of internalized racism, interpersonal racism, as well as institutional racism. And we draw upon definitions of systemic racism as the impact of policies, both formal and informal policies, and procedures that facilitate and empower organizations to engage in discriminatory acts. Systemic racism is pervasive in US society, and it's really critical to address because it disproportionately limits opportunities for work, for health, for education, for historically marginalized and minoritized racial and ethnic groups. So for this reason, it's an urgent issue of social justice, and scholars agree that it really should be the focus of interventions that aim to reduce health inequities. And finally, I just want to mention that addressing systemic racism comprehensively requires multi-level intervention approaches. And this is because systemic racism is prevalent across multiple social and institutional structures and levels of influence. So recent studies have shown that racism is a fundamental cause of poor health outcomes, including mental health outcomes. We know that Black and Hispanic or Latino children experience inequities within schools as well. Data show that Black students are more likely to be disciplined or expelled from school or placed in juvenile detention facilities compared to white students. And Black and Hispanic or Latino students also report disparities in mental health service utilization. They have significantly greater odds of having an unmet mental health need compared to white students. So mental health services and programs that address racism and discrimination are really key to promoting the mental well-being and mental health of racial and ethnic minoritized youth. And specifically, an explicit anti-racist approach that recognizes and addresses those racist structures influencing mental health is needed. So why schools? Well, community-based settings like schools are environments in which multi-level factors, including factors at this macro level or school system in our case, meso levels, high schools themselves, and micro level, family level, combine synergistically to influence mental health. So we felt working in high schools was an ideal setting for a multi-level intervention focused on this topic. Now, while multi-level interventions are well suited for addressing systemic racism, and they're really ideal for improving outcomes like youth mental health, their evaluation does pose some unique methodological challenges for a number of reasons. And I just want to highlight some of those for us here. So first of all, in the case of interventions that are implemented at school levels, all students within the same school are likely to be impacted by an intervention delivered at that school level. So if you deliver a school level specific policy change, all students in that school, in theory, are going to be impacted that. And so as a result, to really evaluate the effects of an intervention delivered at a school level, students within the same school really ought to be allocated as a group or as a cluster to receive that school level intervention or a school level comparison condition. And so as a result, cluster randomized control trials or cluster RCTs, they're really the gold standard here for evaluating multi-level interventions that require allocations of groups to a treatment condition. Now, designing cluster RCTs that are sufficiently powered to test intervention effects must account for the extent to which outcomes of individuals within clusters are similar to each other. This is known as the interclass correlation coefficient. And similarly, on the evaluation end, once data are generated, evaluating data collected through cluster RCTs must employ analytic methods that account for this nesting of individuals within clusters. You can't just analyze data from cluster RCTs using approaches developed for non-cluster or standard RCTs. Another challenge is that some multi-level intervention components, particularly those delivered at a macro level, so systems or policy level change, they might not be optimal candidates for evaluation through a cluster RCT. Now, why is that? Well, multiple clusters might be impacted by this macro level intervention, and there could be financial or logistical constraints that limit the possibility of actually engaging and randomizing a sufficient number of these macro units. And so in these situations, one approach that we employ in our proposed design is implementing a pragmatic pre-post design for evaluation purposes of that macro level intervention. And then follow that by a cluster RCT evaluating other components at the meso and micro levels of influence. Additionally, randomizing students within a school to receive a micro level intervention or a control condition could pose its own challenges. And often a major concern is that the intervention would be inadvertently received by students who are randomized to the control condition, resulting in contamination. And this type of contamination can really shift outcomes in that control group in the same direction as those in your intervention group, and leading us to basically determine that an effective intervention wasn't effective. So in such cases, we really recognize that care must be taken to minimize and to measure potential contamination. And finally, multi-level interventions often involve complex interacting components. Okay, these components typically operating at various levels of influence, they are conceptually hypothesized to interact, to influence health outcomes. And so what do I mean by this? We tend to implement multi-level interventions because we conceptually think there is some added benefit to intervening on multiple levels of influence simultaneously. We think there's an added benefit you get if you do those things at the same time. But we often don't test whether that's true. Standard cluster RCTs randomize clusters usually to a full package or a comparison condition, and so they don't test the interactions. This is a gap, and it's one that we sought to try to address in our proposed design, because understanding the extent of interactions, the extent to which interactions occur, the extent to which intervention components either impede or enhance each other's effects is often of great interest to potential program implementers for many reasons. And one of which is because these types of findings have big implications for how to maximize constrained resources. So in other words, synergies are often unexplored in our standard study designs testing multi-level interventions. So in this visual here, I tried to make this clear. We see that we often randomize clusters to get an entire multi-level intervention, A, B, or not. So yes or no. And then we measure outcomes for those in clusters who are randomized to A, B, and we'll look at the mean of that outcomes for those that were yes, that they got A, B, and compare them to folks in clusters that did not get A, B. And then we'll use that information to make inferences about the effectiveness of that package, of the A, B intervention package as a whole. Okay, so here if we saw these sample data of a hypothetical mean outcome for depressive symptoms measured on a scale of 0 to 54, and we compare data for individuals in clusters who got A, B, and we saw that they had an average of 10 compared to those who didn't get A, B, and we saw that they had an average of 25, we'd likely be pretty excited about these data. Now, this is a simple illustration. We don't get into the variance of these outcomes or intra-class correlations or anything, but just based on these means, we'd have some potential evidence that there might be something going on here, that this intervention package as a whole reduced depressive symptoms. Okay. However, by testing this whole package, we have no way to explore the main effects of those components, right? So how much did component A reduce depressive symptoms? Or how much was driven by component B? Or was component B more effective in the presence of component A? Okay. Generally speaking, in standard cluster RCTs of multi-level intervention packages, we can't answer those types of questions. We can't answer questions like, do particular components depend on the presence of other components in order to be effective? Or are there some components of interventions that don't work well together? So factorial cluster RCTs allow for the evaluation of 2 or more multi-level intervention components at once. And as such, they offer the opportunity to learn a little bit more information about those individual intervention components. They're a powerful yet underutilized design for multi-level interventions. Now, the specific design will depend, of course, on how many components you want to test, but in a basic 2x2 factorial design, testing the components A and B of that multi-level intervention on the previous slide, you could randomize clusters to getting intervention component A or not. And then within those clusters, you could randomize units to get intervention component B or not. Okay, so this table now illustrates a basic factorial design for a multi-level intervention. And then this 2x2 factorial design, you'll see that we would still end up being able to compare those who got A and B. They were a yes for component A, they were a yes for component B. And we'd still be able to compare their mean outcomes for those that didn't get either of them. But this design does have a benefit in that we'd be able to also compare mean outcomes for those that got A compared to those who didn't, and also those who got B and those who didn't, right? And importantly, you'd be able to use the data generated from a trial like this to explore synergies that occur when you get both. So in this table of hypothetical results, you'd see similar outcomes for those that got neither, an average of 25, matches what we saw in the previous slide, compared to those that got both. At 10, you see that those data also match, but you could use these data to start to unpack whether this difference is due to the presence of both A and B. You could plot these simple means and visualize them and see whether there's an increased effectiveness of getting B in the presence of A, as depicted by this navy line being a more sharp decline. And importantly, you could power your study to test the significance of this interaction within multi-level intervention components. And we're gonna show you a package that we use successfully to do a power calculation to inform our proposed sample size. Now, there are limits and there's limitations and strengths of factorial RCTs that I want to mention. Limitations include complexity in design and analysis. So factorial designs within a multi-level context, they introduce more complexity in both trial design and statistical analysis. There is a bump in sample size. Factorial designs require a larger sample size to detect intervention effects and main effects with adequate statistical power. Clustering adds an additional layer of complexity to those power analyses. And these types of designs are prone to contamination, which the intervention's effects might spill over to the control group. But while they do have limitations, they do have some notable strengths that I want to highlight before getting into our hypothetical intervention and analysis plan. So one is that by testing multiple intervention components and testing multiple questions and hypotheses, factorial cluster RCTs, I would say, really maximize resource use and allow us to be more efficient with our resources. This design can also help us identify synergies between interventions at multiple levels, providing a more nuanced understanding of how multi-level interventions work in combination. And finally, another advantage from an equity perspective and from a community buy-in perspective is that a larger proportion of clusters in a standard kind of 2x2 factorial design that I just described, 75% of clusters are randomized to get at least one intervention component. Oftentimes we try to make these evidence-based anyway, and then compared to 50% in standard RCTs that are randomized to get an intervention. So a larger proportion of our sample gets an intervention. And this can really be seen as more desirable and acceptable to community members, which can increase participation and buy-in. So I'd like to shift to talking about our hypothetical multi-level intervention to ground our discussion in our proposed evaluation plan. So our intervention was informed by a heuristic framework that was developed by Guillermo Ramos et al. And Tim Kaiser et al. For conceptualizing and operationalizing the mechanisms through which social determinants of health, or SDOH, lead to health inequities. And I'm going to walk you through how we adapted this heuristic framework for our project on the next few slides. So this framework acknowledges the importance of both SDOH capital and SDOH processes. SDOH capital are defined as socially distributed resources that affect inequities. In our case, that was education, the quality and availability of mental health services. And the framework also informed our focus on SDOH processes. So these are conceptualized as factors that shape interactions between people that influence inequities, partly by influencing access to SDOH capital. Okay, so in our case, these types of SDOH processes included systemic racism. They include school climate. They include formal and informal policies and practices within schools. And they include community and parental anti-racism practices as well. Now, these SDOH capital and processes shape inequities through exposures and susceptibility. So exposures are conceptualized as contact that causes risk to one's health or serves to protect one's health. So in our case, relevant exposures, thinking about how SDOH shapes mental health inequities, was both the experience of discrimination and mental health service utilization. The effects of SDOH on inequities are also mediated through susceptibility in this model, which is considered to be biologic factors that influence likelihood of morbidity. And in our case, this includes family history of mental illness and biological manifestations of stress. And I think most importantly, and consistent with this framework's intention, our intervention strategies include strategies to promote resilience factors at multiple levels of influence that serve to buffer the effects of harmful SDOH on health outcomes. And so resilience here is operationalized across macro, meso, and micro levels of the social ecology of high schools. And I'll show you some examples when I describe our intervention in more detail in the next few slides. So again, our hypothetical multi-level intervention included 3 integrated intervention components delivered across these 3 sociological levels. Levels included the macro level. We define this as a public school system level, a meso level, high schools, units themselves, and then a micro level. So this was families, and the setting was likely within the home. All of these were included to try to best improve mental health among young people. So at the macro level, at that public school system level, our intervention included restorative justice talking circles, which are an evidence-based strategy that increases awareness of consequences of oppressive educational structures and disciplinary actions on students and families. It promotes an anti-racist leadership and has been shown to lead to policy change. The talking circles include district and school administrators from all 30 high schools in our proposed design. And in these talking circles, administrators would also be guided by an expert consultant to examine school policies and school system policies that facilitate discriminatory acts and inequity across race and ethnic groups using a racial equity impact assessment, or REIA. The goal of using that REIA is to minimize negative and unanticipated consequences from proposed policies or practices, programs, and financial decisions. Now, at the meso level, we would intervene with high schools to implement training in racial justice, cultural humility, and mental health first aid for school administrators, faculty, and staff. And the purpose for this training within high schools is to increase inclusive practices among school personnel, which is expected to decrease experiences of discrimination and also improve mental health outcomes among our students. The training would cover self-awareness regarding implicit bias, review and discussion of school policies and procedures, and skills related to recognizing signs of mental health challenges, and partnership building as well with families and students. So now the final level, at the micro level, our intervention would include offering mental health first aid training and support for families. So families can be a source of resilience and support for young people. They're really uniquely positioned to buffer the negative impacts of systemic racism and other stressors on mental health outcomes among youth. And a family-based intervention like this will teach families how to identify and understand signs of mental health distress and challenges, and how to equip them really with skills to respond to challenges by providing support or advocating for students experiencing challenges in multiple settings, including in schools. So now I'm going to discuss our evaluation design, our measures, and our analytic sample. So to evaluate this hypothetical multi-level intervention, we chose to employ a multi-phase hybrid pragmatic and factorial cluster RCT. So our proposed design was to employ a 1-year pre-test, post-test pragmatic trial to evaluate that macro level intervention, the school system macro level talking circles in year 1. We then proposed to follow this with another 1-year 2x2 cross-level factorial cluster RCT to evaluate the effects of the intervention components delivered within the meso and micro levels, focusing on the primary outcome, adolescent mental health, in that second year. And both phases would be conducted with 30 clusters or high schools nested within 3 school systems. Now, this table is an overview of our multi-level intervention and study design. I'm not going to go through all these details. They're in the paper if you're interested. But what I did want to point out is the importance of really mapping out each phase and level of influence to the social cultural context, to the specific intervention, to who's going to receive that intervention, who are the participants going to be, what's the outcome conceptually, and then how is it going to be measured and with whom. So here in red, I've highlighted phase 1. We can see that this is, operationalized at being at that macro level. The social cultural context is the public school system. Our intervention I've already told you about is those talking circles and the REIA. And the intervention participants are noted here. And you can see we have a couple conceptual outcomes, with the primary outcome being that perception of policy change that are going to be measured with surveys with faculty, students, and staff. So here we just detail the analytic methods for phase 1. And you can see that there's 3 levels or units of analysis in that phase 1 analytic plan. These are 2 repeated measures at level 1, or time, and then individuals at level 2, and individuals are nested within the schools at level 3. So the analytic random sample for this phase includes 450 ninth grade students and families, 15 from each of the 30 schools, and then 300 high school personnel, 10 from each of the 30 schools. And those include school administrators, teachers and staff, 10 from each of the 30 schools, and then 30 school administrators, 10 from each of the 3 school systems. I'll note that we decided to focus on ninth grade students because this intervention is likely to have a larger impact during a time when students are acclimating to a new school environment. And also want to point out that participants in our phase 1 will complete a pretest assessment at the start of the school year system prior to the implementation of this macro level intervention, as well as a post-test assessment at the end of their school year, and that a subsample of phase 1 participants would be recruited for participation in a qualitative interview, including all those 30 school system administrators, and a purposeful stratified sample of 60 teachers, 60 students, and 30 school personnel, which we estimated would be sufficient for theme saturation. So to analyze data collected as part of this phase 1, so this is that pragmatic pre-post design to evaluate the effects of that macro level policy change intervention, we proposed a 3-level multi-level model to understand students' perceptions of school system policy change. And we would specify this model as follows. So a student's perception of their school system's policy change, here represented by Y sub Tij, could be modeled as mu, the overall mean perception before this macro level intervention, alpha sub j, the random intercept for each school, allowing each school to have its own average perception, theta times time sub tj, which captures how perceptions change after the intervention, and then this sum of terms that accounts for school level characteristics or covariates, the sum of terms that captures student level covariates and characteristics, and our random error term, which captures additional variability in students' perceptions of policy level change that the model doesn't quite capture. And again, I mentioned these qualitative interviews. So this analysis plan is actually a part of a larger mixed method study that plans to integrate findings from qualitative interviews with key constituents with these quantitative results to better unpack, how did this intervention work? Was it effective in changing policy change in these 3 groups of individuals? So that was all phase 1. And in phase 2, we would have a complementary phase that would happen after phase 1. So in phase 2, all clusters, so again, this is those 30 schools, would be equally randomized to receive the meso intervention or the control. So 15 schools would get the intervention, 15 would get the control. And in this phase, we would recruit a new analytic sample of 10th grade students served in the school system. I'll share more about the sample size rationale, but this random sample would be 102 10th grade students within each of the 30 schools. And then within each of these 30 schools, selected families would then be randomized to either the micro intervention or a control. Okay, so all 30 schools would then have families randomized to the micro level intervention or the control. So to maximize the intervention's effects, the intervention would be delivered to the whole family unit, even though we would collect data from one parent or legal guardian per family. And we would also recruit high school personnel to measure other secondary outcomes of interest as well. So we would be interested in measuring cultural humility and social justice advocacy readiness as well. And these participants would complete an assessment at the start of that second year and at the end of that year as well. So the analysis for this phase 2 is a 2-level, multi-level model with individuals nested within schools measuring our primary outcome, adolescent mental health, assessed at that post-test, but controlling for the pre-test. And this was an efficient way to estimate and examine that cross-level intervention effects between that meso and micro level, which was a focus of this multi-level intervention study, while also modeling the impacts of the macro level intervention. So I'll show you how that gets pulled into this formula. But that was an important note, that this model estimated the students' perceptions of the school system's policy change. That's what we learned in the phase 1. So the 2-level, multi-level model for this primary outcome can be specified as follows. The student's mental health at the post-test, represented here by Y sub ij at time 1, can be modeled as mu, again, the overall mean mental health at the initial time before implementing any of those phase 2 interventions. Alpha sub j, that random intercept for each school, again, allowing for variation between schools. Y sub ij at time 0, so that term representing kind of prior mental health of the individuals at time 0 before the interventions. Beta sub j, the random slope for each jth school. And then our 3 thetas. So we would have theta 1, 2, and 3, and those are the main and that interaction effect of that meso and micro level intervention component. So the first one is that main effect of the meso level intervention on student outcomes. The theta 2 is that effect of the micro level intervention. And then here it is, modeling theta 3 allows us to test that interaction term, which captures the combined effects of the meso and the micro level intervention in understanding the outcome of mental health among youth. So the model also includes the additional school level characteristics. Here is that inclusion of the influence of the macro level intervention that we learned from phase 1. So looking at how that influences our understanding in this second phase, and then including other individual level characteristics as well. And finally, epsilon, our error term, again, capturing unexplained variability or noise essentially in students' mental health that the model doesn't account for. So now a big question that has come up for us when we were doing this study was, how are we going to know how to sufficiently power our study? How are we going to ensure that we have adequate sample size to be able to answer our questions with rigor? So in phase 1, we can simply use more commonly used power analysis programs to first estimate a design effect sample size for detecting an expected difference on a pre-test, post-test pragmatic intervention at that level 1 with sufficient power. And then we can calculate the required sample size by using that design effect formula to adjust for nesting within levels 2 and levels 3. You can see here that we, in the calculation to adjust for our design effect, we've used an ICC of 0.04. And this was, in our case, we didn't have a great estimate of what that interclass correlation would be. This is often a challenge when you're implementing a multi-level intervention for the first time, is you have to make some guesses about if you don't have great data. So we went to the literature, we scoured the literature for what interclass correlations are for different psychosocial outcomes, and decided to aim for interclass correlation that was more conservative, a little bit on the higher end, higher than the mean in the literature, to allow us to have a conservative sample to be sufficiently powered here. And the results of that power analysis revealed that this design effect of sample size of 199 students and families would be sufficient to detect a small effect size for our pre-test, post-test pragmatic intervention with a power of 80 at that significance level of 0.05. So that came to a total for 430 students, accounting for that design effect, or in other words, 15 students or families from each of the 30 schools would be sufficient for this phase 1. And I'll note that these the details for doing these power calculations are included as supplementary materials in our published manuscript. So then for the power analysis for phase 2, this was really exciting for us because, again, we were really interested in determining a sample size that would be needed for the primary analysis in AIM-2, which is testing that cross-level intervention. We wanted to ensure that we were sufficiently and adequately powered to be able to detect an interaction between those two components, should one really exist. And so we use this H2x2 factorial package in R, which is a package that is used to compute optimal sample size for hierarchical factorial trials. So this was really a nice way for us to ensure that we were adequately powered. So you can see here that the results of this power analysis using the H2x2 factorial package showed that 30 clusters would be required for us to achieve 80% power for our interaction hypothesis. So this means we would need to enroll 3,060 students, approximately 102 from each of the schools, to have sufficient power to detect a small effect size of Cohen's d of 0.2 for that cross-level interaction effect of the multi-level intervention with power of 80% and a significance level at 5%. So I want to conclude with some thoughts that our team had as we were wrapping this up, and then take your questions. So a few thoughts. One, I hope that we've conveyed that addressing systemic racism is critical to improving mental health equity. Working within schools is well positioned to be able to achieve these goals, and that doing this requires rigorously tested multi-level intervention. So we need to build up the evidence base in this space. Factorial cluster RCTs of the meso and micro level interventions allow for a more nuanced understanding of potential synergies resulting from the presence of both levels of an intervention, and combining this with a pragmatic pre-post analysis of a macro level policy change intervention, also thinking creatively about using mixed methods, is a way that we can advance this science forward. Our hope is that this methodological approach, including some of the methods that we've described, the limitations and the challenges that we've articulated, as well as the methods for sample size calculation for hierarchical cluster factorial RCTs, can be adapted to other multi-level interventions, as well as we all work together to advance science on designing and evaluating multi-level interventions to reduce health disparities. So I am ready to take any questions. Thank you so much for your attention. And again, thanks to the Office of Disease Prevention for inviting me to share our work with you. Thank you.
Thank you, Dr. Mulliwa, very much. We have a number of questions, as well as some complimentary notes in the chat box, thanking you for your presentation. Let's start with some questions from the audience. Within each of the levels, the macro, meso, and micro, the interventions seem to include multiple components with multiple goals. How do you think about how to specify your interventions with enough detail so that the study tests which intervention components work, or is that even possible?
That's a great question. Thank you for that. This is tricky, right? Specifying our interventions so that they are powerful enough, especially when we are operating at these high levels of influence. We often need to do multiple things to address our goals. I will say we have cited a really nice paper on process evaluation within multi-level interventions that we talked about mapping on to our interventions because they weren't so simple. We would want to be able to complement our ultimate evaluation analysis with a process evaluation to see were all the multiple components of these interventions implemented as intended. Of course, you could, if you had the resources, do, larger factorial studies to tease those out apart. And maybe we can move that way as we go forward. But we thought we could, have a main outcome evaluation and be very clear about what those components are and partner that well with a process evaluation, getting data from surveys as well as interviews to really track how those interventions are delivered.
Thank you. One of the features of this study that you presented is that you have a macro intervention at one point in time, and then subsequently you have the meso and the micro level interventions addressing the same schools. A questioner asks about trickle-down effects from the macro level to the lower levels. And how long did you think it was going to take for the macro level intervention to have its effect so that it would be there and be in the background at least when you introduce the meso and micro level pieces? You gave it a year. Had you given thought to whether that was enough time for the macro level to have an effect?
Great question. We talked a lot about how long to do this and how essential it was to do preparatory work with these schools, with these school systems to build trust before even launching that phase one. So there's almost like a pre-phase one, pre-macro intervention of community building and getting trust and buy-in so that when we launched phase one, it would be effective. Certainly we did hope, that was the intention, that there would be a trickle down effect and that those effects would be sustained throughout year two. We designed our study, trying, even though this is hypothetical, right? We didn't have a specific budget in mind, but we were trying to really balance, would this be feasible? How could we do this? Would this be acceptable? We thought a year struck that balance of being potentially enough as long as we were actively engaged and really ready to start that phase one intervention with the preparatory work so we could, really fully engage so that those effects could be sustained over the year two follow-up phase two.
Thank you. Another question from the audience. While racism is a problem in developed countries like the US, ethnicity is the problem in developing countries like Nigeria. Can we apply the same principles to address health inequality, presumably related to ethnicity as opposed to racism?
Sure, that's a great question, and I do think that while there are some unique features of our U.S. system and our history and legacy of racism here that might not be perfect corollaries, I do think that many of the power dynamics and ways in which power shape our health outcomes can be seen in other contexts and could certainly be applied. I think some of the intentions of the talking circles could be applied to other settings where the power dynamics were maybe not racial groups, but as pointed out, in different ethnic groups in other settings. So I definitely think this could be applied. Our goal is to, not just think about evaluating this specific intervention and how to do that. And of course, we went through great lengths to try to make that feasible, but really how to push that science forward of, if you're going to do that, are you likely thinking that some policy level change might be helpful? And if so, can you partner that with, working with communities to understand a meso-level intervention that might be useful in your context as well? Would it work well with a family-based intervention? And can we test these interventions in a way that helps us move the science forward on the synergies? The specific topic, I think, can be applied to many different contexts.
Implementation quality is an issue in a large trial like this. You've got 30 schools. You're going to deliver your meso intervention in 15 of them. You'd like to do that in a uniform, high quality way. But with 15, there could be some variability. And then the micro level intervention, you've got many, many more units to deliver that to, and issues of implementation quality come up. How do you deal with that analytically? How do you either control for or adjust for, or what can you do when there's variability in the quality of the implementation, which if ignored might push your intervention effect estimate towards the null?
Sure. A few thoughts about this. I think when doing multi-level interventions, having a well-trained team is critical so that you have some sense of everyone being on the same page, because there's going to have to be multiple interventionists working at the same time. Having really systematized processes for monitoring fidelity to the intervention, checklists, random observations of sessions, taking notes and reviewing those notes to see were the main objectives of each intervention session met or not. These types of monitoring fidelity and measuring it is important in any study, but especially in multi-level interventions when you can't have control and be in multiple places at one time. And like you say, working in 30 schools and in multiple families across those schools is a lot. Systematizing that, collecting both quantitative data and observation checklists to try to track and monitor, asking individuals about the dose received, even though our main evaluation design would be on an intention to treat analysis. It would certainly behoove us to do an analysis to look at dose response or of the intervention received, or trying to measure and account for quality of that intervention as well.
One of your slides, or maybe it was a couple of your slides, showed outcomes for different levels, and each level seemed to have of your intervention seemed to have a different set of outcomes. That raises questions of multiplicity. Adjusting a type 1 error rate for the number of measures. You may have had a single measure at each level that was primary, but even if you did, you've got 3 levels in the study. What is your thinking about addressing the issue of multiplicity here?
Yeah, so we did ultimately feel that it was important to pick one primary outcome for each of the levels. And I will say, this is, again, we were not designing for a specific budget or item, but we wanted this to be feasible. And it does become a major challenge to have even just 2 and doing 2 primary outcomes, correcting for that in terms of correcting for reducing that type 1 error. I will say that when doing these multi-level interventions, we may need to think really creatively about using mixed methods and other evaluation approaches to evaluate those secondary outcomes. Prioritizing one, it becomes infeasible to just financially and logistically to move much more beyond what we've set our power calculation to. But using some of these other evaluation approaches or complementing this with a mixed methods analysis to really increase our confidence that the results we are detecting with our statistical analyses are true, that they, are not the result of chance, especially critical when we get to some of the secondary outcomes where we know we have, at least in our case, we opted not to have a correction for multiple comparisons, but rather trying to partner that with a mixed methods analysis as well.
Sitting here asking my question, and I'm on mute, so nobody could hear me.
Glad to see what was happening.
Yeah, sorry about that. I want to ask a question about the macro level intervention and the design that you use to evaluate the macro level. It's an uncontrolled pre-post design, and you would agree that that is in and of itself not a terribly strong design. But it lets you say something about macro level as opposed to not being able to say anything, and so that's useful. One of the ways that might be helpful to you in terms of strengthening the inference would be the addition of an outcome measure at the macro in the macro level phase that you wouldn't expect to be affected by the intervention, or maybe even several of them. And then if you see a change in the one that the intervention is targeting and you don't see change in some others that might be at least somewhat related, that gives you a stronger case, and you haven't had to add any schools, you haven't had to add any participants, you've just added a few additional measures. That's a thought.
Yes, that's not something we considered, but I love that idea. And yeah. I think that would be easy to, like, the idea here, and totally agree, not the strongest design, but allows us to evaluate and understand that important level that we're often talking about, but we're not able to, have the resources to really rigorously, with statistical power, evaluate. But at least measuring and then being able to include that measures in our subsequent phase 2 analysis seemed like we could also get some sense of whether the effects of having schools with higher levels of policy change were more likely to have an effect in phase 2. But yeah, being confident about that phase 1 finding by adding outcomes that we wouldn't expect to see change in would certainly increase our confidence in that inference that we would be hoping to make in phase 1.
Right, especially if they were related to the outcomes that you were expecting a change in. In general, I'm thinking about the lessons that we've learned over the years from Campbell and Stanley, Cook and Campbell, Shadish, Cook and Campbell, who talk about strengthening inference when we've got non-randomized designs, and that's what the macro level is. And adding additional outcomes like that is one way. Another approach would be measuring the outcome of interest, but several times before the intervention is introduced, and then several times after. And it would let you look at trends as opposed to a single point in time. Now, granted, that's harder, it costs more, but that's another idea.
That's true, and that is actually one that we had considered, and then just feasibly thinking, oof, that would be a challenge, but certainly would help us kind of combat some of those threats to the internal validity of the findings, not having a comparison condition.
Right. The equations that you showed for analysis, I believe, included covariates, and I suspect that your thinking was that you could improve the power of the analysis by adjusting for covariates. How do you decide which covariates to measure, which covariates to include? And in many trials, at least funded by NIH, the expectation is that you're going to specify those in advance, not poke around and find them once you've got the data.
That's true. That's true. We did hope that including covariates would allow us to improve our models and increase our ability to detect significant effects, and did discuss the need to pre-specify those ahead of time. You know, we tried very hard to ground our intervention in a theory, in a understanding of what the mechanisms of change were, and in thinking about how to design an intervention at these multiple levels of influence that, based on our theoretical assumptions of how these SDOH capital and resources shape mental health inequities, would be likely to see change over time. And so I would think that mapping on the selection of covariates to theory would be a great way to specify those ahead of time. Obviously, looking at the published science as well to understand, are there characteristics of schools? We talked about school size, trying to, we have a section in our paper where we also talk about potentially matching in our randomization at the school level and the pros and cons of that. But thinking of, are there characteristics of schools or individuals that we know based on our theory and the empirical evidence that are likely to be impacting the ways in which this intervention can work, would be how we would try to select those and pre-specify them if at all possible.
Right. In any variable that's related to your outcome and can be expected to vary amongst the schools is going to contribute to interclass correlation. So if you can think about what some of those things are and adjust for them, then you reduce the ICC, and that can have a big payoff in terms of improving power.
Right.
We have a question about whether the package you use to compute sample size accommodates unequal cluster sizes. Nobody ever does a school-based study where all the schools are the same size.
That's right. That's right. It actually does. So in our study, we chose for this illustration to have equal cluster sizes within each of the 30 schools. So planning to recruit the 51 students and families from each of the schools. But the H2x2 factorial package does actually allow you to compute the sample size calculation even when you have unequal cluster sizes. So, and again, it's really designed for testing, designed for powering your studies to test cross-level interactions and hypotheses in hierarchical or multi-level interventions. So we thought this was a great resource to put out there. And an added benefit is that, yes, it does work when your cluster sizes are unequal.
We have two people who have asked if you can use directed acyclic graphs to identify covariates that you might include in the analytic models.
I think you could, though I would say that pre-specifying them ahead of time before you have the data to generate those graphs would be our preference. Already we have a number of factors included in these models. Already there's multiple things we would want to be controlling for, and to the extent that we can pre-specify them without data yet available to generate those graphs would I think be the preference.
Dr. Mullah, I want to thank you very much for your presentation today and for this conversation that you and I have been having. Unfortunately, there's not enough time to get to all of the questions, so we will be sending some of them to you and encourage you to provide written responses that we can post. but it's time for me to turn things back over to Dr. Moyer to wrap up.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. On the Mind the Gap website, prevention.nih.gov/mindthegap, you'll find several resources for this talk, including the slides and a list of references. We will also be posting a recording of today's webinar on our website in a few weeks. Thank you and have a great rest of your day.